here we go. We have a double arch case today. We have a patient who is 44-year-old female, edentulous upper arch, quite a bit of bone loss, chronic perio on the bottom. This is how I'll explain to the patient what we're doing. I'll draw an R up here and say, hey, this is the right side of the x-ray. This L shows you the left side. Here is the joint. This is where it sits into the skull, and I'll kind of point over here. I'll trace the sinuses here, trace the nose. I'll tell them their nose isn't that big. It's just them flattened out into a 2D image. Sinuses on the left side, joint here. Here's your nerve. Here's your nerve on the right side. And when you were 12, here's where the bone levels were. And as we sit here today, this is where the bone levels are today. And some version of this as well. You can't really draw when they're edentulous, but this is what we're working with. When I see a case like this, I'm evaluating the sinus location, where the hamular notch is there, where the hamular notch is here, and are we going to be able to get a pterygoid implant in here? If that's not in your armamentarium right now, you can place an implant here, a 5x8, and do a vertical lift, and then find somewhere here to potentially get one in here and place a 5x8 and get a vertical lift. Just knowing that most likely than not, your stability isn't going to be there, but at the same time, you can come back and uncover those implants after they've integrated after 3, 4, or 5 months. And then usually we'll place an implant somewhere right around here and an implant here. We always get check x-rays on this. Mac is a big proponent of making sure I'm checking things. How many times have you seen me miss?
A few times.
A few times. So like even when you do this a lot and you do these, you place your first pilot drill in there, if you don't get a check x-ray, potentially you could do this, right? I got a handful of these out there that do this, where this component of the implant is just inside the sinus. And so what we'll do is we'll go through the same osteotomy, and I'll really force it this way, and I'll force it this way. We get another check x-ray, and we make sure we're in the bone. Then probably one here and one here. And then on the bottom, shorty here, one, and one. So at the end of the day, this is kind of what we're going to be looking at when it comes to the surgery. So we have the upper planned out, and you can see where the pterygoids are, where the spread is of the implants. We're going to definitely 100% drill through and into the nose and engage the nose and get the bicortical stabilization. Same thing here. This is a 13mm implant. We might place 16 or so and engage the base of the nose here and engage the corner of where the nose and sinus meet over here. Do you see anything that occurs when we do this, Michaela? Like when we do this approach, do we ever get into any trouble or any like obstacles when we're placing these angled implants or these anteriors?
Not usually. I have seen if you hit the nose, possibly like a bloody nose. You can see that through the oxygen that the CRNA has down the tube. But I haven't seen anything major.
Okay. So a bloody nose means when you've drilled into the nasal cavity, you've definitely drilled too far and you've, started a bleed inside the soft tissue in the nose. So when you hit that cortical bone, hit it and then be very, very controlled with how you kind of perforate through it. But you do have to perforate through it at 2000 or so. You just have to check and make sure when you perforate through the nose that you're not going so far in that you're going to create a bleed, because then you got to deal with blood inside the nose or a significant amount of heme coming out of the osteotomy. If that does happen, you can go ahead and put the guide pin inside of the osteotomy, and it can help block up and plug up the bleeding coming into the mouth and obstructing your view. What about the pterygoids when we're doing these? Do you like to do them first? Because I was planning on doing these first today, and then figuring out, okay, did we hit the pterygoids and get stability? And it's going to help dictate what I do in the front.
Yeah, I like pterygoids first because then we know how far back we have to spread, like the premolars. We have to go back to the molars to get them their first and second molars, or if the pterygoid is sufficient enough.
Okay, awesome. And then let's see, we go to the bottom. So this is the spread on the upper. Pretty straightforward. You know, we have measurements. Most likely than not, the implants are going to go deeper than this because we're going to go a couple of millimeters subcrestal. I find when I go 2 to 3 millimeters subcrestal, I get a really nice emergence profile on the prosthetic, where the prosthetic is going to be nice and flat and not have these concavities to it. So most likely than not, that 13 is going to be in the nose and engaging into the nose. 2 millimeters into the nose and into the sinus, not a problem. You start getting to 3, 4, 5, like you got to pick a shorter implant. So make sure you just measure appropriately when you do this. It'll save you a whole lot of time. Here, kind of the same thing. Imagine this going a couple of millimeters higher and then perforating right over here and getting that bicortical stabilization. Some people like to come up in this direction and angle it that way. Absolutely possible. If you pick a longer implant, you can do that. I don't think it's necessary in this situation, but if the bone density was really, really low and I go in there and it's like styrofoam, then I would change the approach and start engaging this more cortical triangle in that area. All right, and then for the bottom here, pretty straightforward. All the teeth come out. This is kind of atypical. It's a very dense mandible. So more likely than not, we're going to be drilling to the appropriate size on the drill sequence versus under prepping, where when we come up to the maxilla, we're going to be under prepping the osteotomies pretty significantly. Maybe I'll prep to what, like a 3.5?
Yeah.
Or I even take the 3.5 in halfway. When I under prep too much, what do you typically see happen?
The bone flexes.
Okay. And then at what point do you tell me like chill?
When it's like super white, I see the bone like turn white and I can really see it flex and I'm like, you should take it out and re-prep.
Okay. And so you should, because sometimes I'll start to see this fracture happen on the buckle. And then if I get, lazy or I just think I can, back it out and go in, back it out, go in, sometimes they'll actually just crack. And then you lose your stability completely and you've blown out your site. So at the end of the day, you start to see that bone get really white. Just know the implant is compressing the cortical bone on the facial so much so that it's going to create like potential necrosis issues, if not fracture. So what you want to do is take your implant out. You don't want to drive the implant all the way in and then have to remove it because now you have this huge osteotomy. So take it out when it's halfway in, and then take your drill in, but be intentional about drilling on the palate to create more of a reservoir for your implant. So on the palate, you're drilling more this way. So as the implant goes in, there's less pressure towards the buccal where the fracture is already occurring. So I'll take it in a sawing motion and I'll just run my drill along the lingual or the palatal, and I'll just create more space in that region when that flexure happens.
I've also seen the implant piece that you have on the ratchet.
Oh shit.
If you're going too hard, you can bust that inside the implant and then game over.
Okay, and Michaela's 100% right. You break that piece inside of your implant, it cold welds inside your implant, and then you actually physically have to remove the implant. Well, your driver to remove the implant can't fit in there because there's a piece welded in there. So at the end of the day, you got to try to grab it and rotate it out, or you have to,
drill it. And then
then
you lose the whole site sometimes, depending on how far the implant's in.
Yeah, because when you have to trephine it out or drill around it, you're just creating a lot of heat. That burr hitting metal or the trephine just rotating into the bone creates a lot of heat. And then obviously the void that forms is pretty huge. So don't over torque these things. You want to get torque, like, what they call chingo torque or a shit ton of torque on these, but you start getting way over 60 and your implant's not where it needs to be. Back it out a little bit, take it in, back it out. And if it's not going anywhere, take that sucker out, drill more. It's a bad habit I have because you get so used to doing these things. You just want to like ratchet these suckers down and get maximum torque. There is too much torque that can occur. And it's not too much torque in the bone that can occur. Typically speaking, it's too much torque within the parts and pieces in your prosthetics that can, start to break. What else do we usually have hiccups on?
I think that's about it.
Okay.
Just taking that extra time to, like you said, take it out and re-prep.
Yeah.
Bigger things can happen.
Yeah. So what we're going to do is we're going to touch base with you afterwards. And we'll see, the patient's going to be sedated. Sometimes when they wake up, we can't get a CT because they just can't hold still. So maybe we show you the pano secondarily, but we'll give you the debrief right after the surgery. We're going to take pictures and videos and kind of talk through what we're seeing while we do it. And obviously, you guys have any questions, please post them and we'll answer all of them. We are doing the debrief on the surgery for Miss Amy here. And I guess why don't we start from the top in terms of just like what we did. So, first we placed, well, actually, first we,
Flapped. Incision and flapped.
okay, incision and flap. Well, let's go back to anesthesiologist.
Okay.
And then we actually found out that the oxygen wasn't on. So we had to run down and switch the oxygen on. Like what
Well,
was the tank empty or like what was
tank
going on?
had like 5 seconds left in it.
Okay.
So we turned oxygen on, it had like minimal use. And so we crank it up and then it turned off.
Okay.
And so we had to run to the basement, switch the tanks, which took maybe 2 minutes, but that's 2 minutes of patient desatting.
Okay. And so what did we have in the room?
We had
Any
just
tank?
the O2 tank.
Yeah.
On the side, so we started to hook up the patient to that, but by the time the anesthesiologist opened the tank and was switching the tube, the oxygen was already up and running, so it was very quick.
Yep. So I'd say a version of always have a backup e-tanks in your office if you have plumbed oxygen, or always have extra oxygen regardless. And then what we did is we put 2 TADs in the pallet. So one here, one over here, actually more of a one here and one right here. I don't always drill all the way through, so I don't drop into the nasal space. I'll drill a little bit in so the threads of the screw can the threads of the TAD can engage. And usually that's enough, but I'm usually taking it in about like 3 or 4 millimeters. But sometimes if you push too hard, it'll just like drop right into the nasal space and you get a bleed out of there. And you got to put your TAD somewhere else. And then on the bottom here, this was pretty easy. We placed the TAD right here. And then on the bottom here, I asked, well, should we leave this molar as our TAD? And then why don't you like leaving the molar as
because then when surgery's done, you can just like leave the room and I finish records. I take the TADs out and then we wake up patient. If you leave a second molar, then I have to go back and track you down, bring you back in to extract. And I like to clean up the room as I work, so I can get rid of, all the extraction stuff once the teeth are out. I don't have to keep some stuff. So it's more efficient for the team. So if we do like a late surgery, thankfully this one was early, but if we do a later one in the day, I don't have to keep the team with sterile.
Okay, yeah. And then when you also take this out after your surgery is done, if you used it as a TAD, you got to graft the site. You got to resuture the area. It just takes longer. And plus, like we're moving on to the next thing, hopefully. Or sometimes it's just you don't want to go back in afterwards. Okay, so then yeah, we flapped the upper. The tissue was super, super thick. I mean, I haven't put that much pressure into some tissue in a long time. So I put a vertical right down the middle here, and it actually helped quite a bit. We reflected to the pterygoid here. So the incision went down to the hamular notch. So, the incision started here. I buried the whole 15, came up over to the middle, and then came over here. And then what I did is I had the 15 backwards and I just dragged the tip of it this way to kind of score the bone. And I went here and went backwards. So you're not creating a secondary incision. You're just scoring the bone and getting all the little fibers off the bone. So when you reflect it, it reflects a little bit better. I also like doing the anesthesia where I'll do the PSA back here. And then I'll kind of come up here and do the infraorbital. Sometimes I'll deposit some like right under the nose here and here. Go do a PSA here. And then on the bottom, just blocks and like a bunch of local everywhere. And then I'll also drop some in the floor of the mouth in this region and just do the anesthetic. I like to do that before we do the TADs and the scans and all of that, because the longer time that the anesthetic has to set in, is the epinephrine has a longer time to vasoconstrict, which means when I start the incisions and everything at that point, there's just less bleeding that's going to occur if you have more time for profound anesthetic to kick in versus just doing your anesthetic and then picking up the 15 because the patient's under and getting started. Okay, so struggled on reflecting, but reflected it nonetheless. And then there's a little bit of unevenness in the bone, so we just kind of leveled it out a little bit, smoothed everything out. And then pterygoids first. And then we talked about why pterygoids first. Do you feel like that was the right decision?
Yeah.
Okay. So we checked the burrs. Each burr with the pterygoid had bone around it. You can kind of see it's like a little bit more cortical. So you feel like you're in the right place. Now we don't have a CT on the patient to confirm it's in the right place because when they wake up sedated, they can't stand still. So we always, get it the next day. You could always keep them a little bit longer so then they can stand and you can get that x-ray. It just depends on personal preference. But what we did is we came in and let's delete the whole thing. It's not. Oh, I'm not deleting one at a time, am I? Okay. Okay. So came in and dropped the pterygoid here. Came in and dropped the pterygoid here. And then what do we do? Just these angles?
Yep, angles.
Okay, so this angle I thought was pretty good. This angle I thought was a little close to the sinus.
Yeah, we redirected.
And so, yeah, it was here. So this feels like sinus here, right?
Yeah.
Like this. And I don't know how much redirection I actually got. I'll be interested to see the x-ray. I dropped this. Let's see. So we started here and I was trying to do, no, that doesn't work. I was trying to do that, but at the end of the day, I think when we look at the x-ray, when all is said and done, this is the sinus. So we got some of that in there. We'll probably see it end up, probably some of the implant is going to be within the sinus over here. That's what I think is going to happen, but I'd be interested to see if we were able to redirect that. Here in the anterior maxilla, I did 4x11s because we did a little bit of bone reduction. So we'll kind of see like, okay, I definitely felt bicortical stabilization when I placed the implants. But we'll kind of see how much, engagement we got there. Was there really any concerns with placing the implants on the upper? We just had to over prep.
Yeah, we had to re-prep. Remember you took the implant in and then I suggested to take it out and take a bigger drill. And so we did that.
Yep. So what happened here was, this is my crappy drawing of a neodent implant, but this tapered component of the implant is a triangular, it's a cutting thread. And then the square part of the implant is trapezoidal, is compressive. So that's on neodent, you get like a crap ton of torque, but also the implants grab. So when the implant torques out here in this like tapered area, the next part of that implant going in is going to be a lot of compression. So if it torques out around here, you got to maybe take it out and re-drill. So we actually, took the implant out. Mac was right. I was probably going to force it in, and we ended up not doing it. It worked out way better. But we took it out, and then the implant came out to about here. So now when this part is just standing tall here, and at the end of the day, driving that in, out, in, out, in, out, all of that worked way better. So we actually ended up doing that here, 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 and here because of the density of the bone. And I think it worked out better. And I'm glad we actually did the pregame talk because it primed me in my head to not just force it in and just ratchet these suckers down because she was seeing the blanching in the bone like we talked about. So we had 6 implants up top, kind of screwed around with the multi-unit position. We were evaluating her tongue. And her tongue sat really high over the occlusals of these lower teeth, just at rest. You can see the tongue swell. And if you see that, and we already got sleep tests on her for 3 consecutive nights before the surgery, which showed she was like mild, almost in that moderate territory, just a high mild. And when you see that, you don't want to over constrict them from where they started, because then you're going to make the airway worse because that big tongue is getting forced back into their airway space. Let's see if we capture that here. Yeah, I mean, you can even see it.
Yeah.
And so a version of what I'm going to be implementing into the future is myofunctional training on implant patients. And so we can train them to, pre-surgically, hopefully, to get this tongue up onto the palate and to really like train them to get their tongue up and out of their airway. Because you can see this takes that garden hose and constricts it into a coffee straw over here. And so I'm surprised she was only mild, quite frankly. After looking at this, I don't know. If she was to have like a alcoholic beverage or something, I guarantee she'd be moderate, maybe even severe. So then what we did is we placed our multi-units at different angles to really expand the maxillary arch and create as much space for the tongue as possible. Then we did that on the mandible also to some degree, you know, over here we put in 17-degree multi-units that were flaring out. So up top here, the pterygoid, what kind of came out almost straight.
Yeah.
And then this one flared to the buckle. And then this one, I mean, no, it's actually flared buckly, right?
Buckle as well,
Yeah,
yeah.
buckle, 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 and then just straight here. And then this one we flared to the buckle. Maybe a little bit here, a little bit here, but we flared this one to the buckle because we're just trying to create space for the tongue to exist and not just trap it in backwards.
Mhm.
And then if we look at her, you know, from this angle, I mean, you can see just how much atrophy occurred from the maxilla to the mandible. I mean, we don't know where she started from an occlusal perspective, but, you know, maybe she was a little class 3 in the beginning because this is a pretty significant difference.
Yeah.
So with the prosthetic, you know, we flared all these uppers. We kind of put these lower ones a little bit more straight. So hopefully we can jump her into a class 1 when we get the prosthetics in. So hopefully tomorrow goes well with the design. On the bottom, do you think we ran into really anything at all?
No, we kind of just learned from the upper and did the same thing on the lower. So lower went a lot quicker.
Way faster.
Yeah.
What I did is, you know, we re-anesthetized a little bit, kind of, you know, just to top her off. And the anesthesiologist was able to tell us like, hey, you know, her blood pressure's up, creeping up a little bit, her heart rate's creeping up a little bit. That's an indicator you can give them more anesthetic. So we did more anesthetic, and then we just pulled all the teeth first because they're perio involved. I didn't even elevate them. And then I made an incision on the buccal and then kind of through the lingual to kind of cut out all the papillas because all this perio, you know, tissue here, just all crap. You need to get that stuff out of there. And so, you know, 2 incisions and then kind of left, you know, all the papillas and all the crap in the middle. And then when we peeled it back, you can just start popping out all the granulomatous tissue and really cleaning it out nicely. And then we reflected from, you know, here to here. I didn't make any verticals. We, you know, just evened out the ridge with a straight handpiece and a zirconia acrylic burr. And then place the implants, and it's pretty straightforward, right?
Yeah.
Just bone graft suture,
Mhm.
finish up. So either way, I think the case went well. I liked the debrief in the beginning.
Yeah.
I would say the only thing when we maybe review the X-ray is going to be this multi-unit. When they placed a 30, it kind of did that. I'm being dramatic with the angle, where I think a 17 would have been straight up and down. Outside of that, I think everything else went really, really well.
Yeah, I agree.
Okay. Anything we could do better?
No, I don't think so.
Okay.
Maybe just multis, like we said.
Yeah.
If we don't like it, it's better to take it off now than do it in 8 weeks. You
Yeah.
can't touch it until like 6 weeks.
Okay. Yeah. And then if you take off your multi in 8 weeks, well, guess what? That multi costs you an extra $150. You got to rescan. Designers are going to charge you more sometimes when you do new photogrammetry and new stuff versus just redesigning, and that's usually baked into the cost. So sometimes, I mean, fixing it on the surgical date and just handling it if you don't like it is a good idea. So probably that's what I would have taken care of.
Yeah.
All right. Pretty good one. Okay. Thanks, Mac.
Mm-hmm.
We are going to do the review for the post-op video for Amy with the Pano and CBCT. So obviously, right side over here. Here is the sinus. Here. Nose. Sinus. And then lower. Looks pretty level. If anything, maybe I bring this implant over here. Get a little bit better spacing. And then you can see a little tilt to everything. I was sitting down and doing the surgery from the right side. So if anything, slight correction in angulation would look a little bit better on the x-ray just for symmetry purposes. Not going to affect anything one way or the other. And then we get into the CBCT. What I'd like to do when I'm evaluating this is go on top of every implant and I get the crosshairs or the alignment down the line of every implant So I can really see the angle. So you can see a lot of cortical bone in this pterygoid region here. This is a 4x16, and we can see where it terminates here. Pretty much right down the center. Here's your lateral wing, medial wing, and then kind of tracking that guy down. So looks good. Right behind the sinus. Happy with that location. Okay. Looking at this one over here, say the vast majority of this one is housed in bone, but I'd say a small little sliver of it right over here is in the sinus to some degree. Not going to affect anything one way or the other. If I'm being super critical, potentially angle this guy a little bit more this way, and then the 30-degree would be a little bit more vertical versus the 30-degree not being as parallel to the adjacent implants. So that one maybe needs a little bit of improvement. This one over here. Now, when I was drilling, and we took videos of the actual surgery as well, but I did come and pop through into the nose, but here we chose a 4.5x11 versus a 13. Maybe a 13 here is better because you get a little bit more bicortical stabilization. But let's say I didn't drill all the way through and I placed that 13, this would bottom out here. And all the torque on all the implants was like 60 plus, some maybe 45, but the vast majority were torquing out. So I get over here, it bottoms out, I start to drive it down further, and it would go from 60 to 40 to 30 to 10 to none because the implant can't drive up any further. So it's going to bottom out and it's just going to auger out. So at the end of the day, make sure if you're getting close to any cortical plates, you actually drop into the nose or drop into the sinus. So that way the implant can advance further if you're going to drive it down further. Okay. Other anterior implant. This one looks good on the bicortical. Just right there, really just engaging the base of the nose. Now, 2 millimeters into the nose or the sinus, not a problem at all. A little bit more than that, you potentially might have some inflammation, some irritation. So at the end of the day, just kind of be aware of that. So this implant here is a 4x13. You can see it's engaging a little bit of the floor of the nose in this region. It's not a bad thing. But the angle on it, if we look at it here in the axial view, it creeps in way too medial. So if I wanted to redo this one, I would potentially try to have it, instead of it going medially, which is not bad. I'm not worried about this one at all. I'm just giving you the critique. I would try to have it come more this direction and engage more native bone towards this direction here as well. So following that track versus it creeping in medially like it did. And then let's go check out the pterygoid on the other side. And again, all this is freehand and not guided. I prefer freehand. No knocks on guides. Guides work well when they fit properly. And if they don't fit properly, then you got to kind of, pivot. So over here, we're seeing the angle of where the apice of the 4x16 is ending up. Really good stability on it. As I drove the pterygoid in, I had to go in and out and in and out. I just was kind of expanding that region. It got tight enough where I felt like maybe I should take it out and prep a little bit more, but we were so close to the finish, I just kind of went slow and rotated this guy in. If you put too much pressure into this really cortical bone, you can pop the pterygoid and create a fracture and then just lose all your stability. So at the end of the day, I was happy with this placement. You can kind of see where it goes. Lateral wing, medial wing. So, and a lot of people are liking these guys to be more medial versus right down the middle. So, dealer's choice on this, but at the end of the day, just don't be too lateral. And let's go and look at the lower implants. This arch was much more straightforward. The bone was very dense, so I actually ended up prepping up into diameter of the drills more than I typically do for full arch, and got really good stability across the board on all of these. The angle on this seems like it's coming really facial, but when we kind of lined everything up and we look at it, in this region, it was coming up and straight and down. So this is just, kind of deceiving to see on the X-ray. Over here, kind of the same thing. All housed in really good cortical bone. Same thing here. And same thing here. No real concerns on the mandible. The tissue was thick and healthy. I'm not overly concerned with incision line opening or anything like that for this patient. So in general, it was relatively straightforward. The upper, there was some areas that could potentially use a little bit of improvement. On the lower, maybe a little bit of spacing issues on the bottom. These are vortex screws holding the prosthetic in. Currently speaking, I'm using vortex screws or the DES 19.018. There's a lot of different screws out there, so it's just whatever works best in your hands. We were using the iCAM for photogrammetry, the Trios 5 for the intraoral scanning, and the Sprint Ray or Einstein. I'm not sure which one the lab used on this one, but they might have used Flexera for the resin temporary. Please reach out to us at coloradosurgicalinstitute.com if you have any questions at all.